Bismillah ar-Rahman ar-Rahim. Silicosis. This is a chronic nodular densely fibrosing pneumoconiosis caused by prolonged inhalation of silica particles, long lag time of decades between exposure and clinical disease. There is insidious onset and progressive course. The larger radiological opacities are seen more than those or larger than those seen in co-workers pneumoconiosis and is more rapid progression. The pattern of disease depends on the level and duration of silicon dust exposure. Silica is present mostly as crystalline quartz, which is mined and quarried and is used in industries such as ceramics, brick makings, and stone masonry. It is becoming less prevalent in Western societies due to changes in silica working conditions. Pathology. Quartz and cristobalite forms of crystalline silica cause silicosis. When they accumulate within the airway, lymphocytes and alveolar macrophages engulf the particles and are removed into the lymphatic system. Any remaining silica dust causes focal aggregation of macrophages, which are in time converted into fibrosing nodules. The silicotic nodules Silica dust can cause surfactant secretions from the alveolus to local irritation. This leads to further macrophage recruitment. Large nodules are formed by aggregation of smaller nodules. Differential diagnosis or different types of silicosis. There are four types, and the distinction is often not clear. Acute silicosis, which caused by intense exposure to fine dust such as those produced by sandblasting. It may become apparent in workers within a few months to a year of starting work. Rapid deterioration over 1 to 2 years, with treatment being ineffective. Rare now due to regulation of silica levels in the workplace. Clinically, dry cough, dry cough, shortness of breath with a feeling of tightness on breathing deeply. There is rapid deterioration over a few weeks, and in examination there are fine crepitations which heard over the lower zones bilaterally, and there is respiratory failure, chest X-ray, patchy bilateral lower airspace consolidation, which may block like pulmonary edema. The pathology, there is irregular fibrous adjacent to alveolar space or alveolar space filled with a lipoproteinaceous exudate, similar to that found in the alveolar proteinosis. Subacute silicosis. This is a classical form, or this is a classical picture of silicosis, which is now quite rare. Dry cough, gradual onset of SOB. Chest X-ray, there is upper and mid zone nodules. There are upper and mid zone nodules measuring 3 to 5 millimeter mercury in diameter, initially indistinct from becoming deeper or become initially indistinct, but become clearer with time. Nodules coalesce, coalesce and calcify and can progress to progressive progressive massive fibrosis can progress to progressive massive fibrosis PMF, where the center may cavitate. Associated calcified hilar lymphadenopathy, eggshell calcification, and the possible pleural thickening. Nodules continue to develop with continued exposure, but due to long lag time, will also develop when patient stops being exposed. In some cases with heavy exposure to silica, patients may develop progressive upper zone fibrosis with sparse nodularity. Pulmonary function tests show decline, including total lung, including decrease lung transfusion for carbon monoxide with mild restrictive pattern, unless the silicosis has caused emphysema and obstructive or mixed picture steam. Pathology: dust particles within the alveoli are phagocytosed by macrophages. They are removed to the lymphatics where they lodge and cause diffuse inflammatory change, such as